Welcome back to the deep dive. Today, we're stepping away from the usual suspects, the fractures, the arthritis, the acute piers.
Yeah, we're going deeper.
We are. Our focus is, well, let's call it the knee's hidden architecture, the non-traumatic, non-degenerative, sort of inherent structural quirks.
The stuff that's been there all along.
Exactly.
Yeah.
And our mission, using some key insights from Insall and Scott, is to figure out which of these anatomic aberrations are just, interesting footnotes and which ones are actually clinically significant landmines waiting to go off.
That's crucial. I mean, as surgeons, we're geared to fix the break, right? But what if the patient's original blueprint was, let's say, less than ideal?
Mm-hmm.
You can do a technically perfect ACL reconstruction, but if you missed severe trochlear dysplasia, for example, well, you're setting that patient up for failure because the fundamental mechanics were off from day one.
So think of this as like the ultimate pre-op consult for the weird stuff. A clinical shortcut, maybe? We need to separate the, oh, that's odd findings from the, oh, this changes everything findings.
Yeah, or like that grand rounds case that keeps you scratching your head. The MRI clearly shows a meniscal tear, but hold on. Why is the trochlea shaped like, well, a flat plane instead of a groove?
Right.
It's only by spotting these anatomic aberrations that we can actually tailor the fix to the real problem, not just the symptom it caused.
Okay, let's dive in. Right, starting with the literal foundation. The bony box itself.
Yeah.
The femur, the patella. If this structure isn't right, everything built on top is compromised.
And you absolutely have to start with trochlear dysplasia, or TD. It's a huge player in why some people get recurrent patellar instability or that nagging anterior knee pain.
But it's not just the shallow groove, is it? The sources emphasize it's more complicated.
Oh, absolutely. It's rarely an isolated villain. Think of it as the ringleader of a gang. TD conspires with other factors, the actual shape of the patella itself, whether the patella sits too high, patella alta, how competent the MPFL is.
The medial patellofemoral ligament.
Right. And, of course, the muscle balance, especially the VMO, the vastus medialis obliquus. It's the whole package.
So when a patient comes in with that classic movie theater sign, the anterior knee ache when sitting with the knee bent for a while, or they get sharp pain squatting or climbing stairs.
TD should be jumping up and down on your differential diagnosis list. But, and this is critical, you can't just suspect dysplasia. You need to measure it, quantify it.
Okay, let's get technical. The radiological measurements,
Yeah.
we need numbers, right? Hard data to define how bad it is and if surgery is even on the table.
Exactly. First up is the sulcus angle. You measure this on an axial view, like the merchant view. It tells you how deep that V-shaped groove is.
And what's normal?
Well, the mean is usually quoted around 130 to 137 degrees. But the range is pretty wide, like 112 up to 151 degrees.
So higher numbers are bad here. Like 150 degrees means it's flatter.
Precisely. The wider the angle, the flatter the trochlea. Less bony wall to keep the patella tracking properly. The sources are clear. You see significantly wider angles in patients with recurrent dislocations. It's often your first hint on a plain X-ray. Like in Fig 2.1, you can really see how shallow that groove looks compared to normal.
Okay, sulcus angle. Got it. What's next?
Then there's the lateral to medial trochlear ratio. This looks at asymmetry. Is one side of the groove underdeveloped compared to the other? If that ratio gets above 1.7, that's mathematically dysplastic.
Captures the subtle imbalances.
And then you have to look at the tibia's position relative to the femur. This brings in the tibial tubercle lateralization.
The TTTG distance. Tibial tubercle to trochlear groove.
That's the one, measured on axial CT usually. And there's a magic number here we really care about.
Which is?
20 millimeters. If that distance between the tubercle and the groove is more than 20 millimeters, it's considered abnormally lateralized.
Why is 20 millimeters the cutoff? Why is that number so sacred?
It comes down to biomechanics and a lot of clinical data. Basically, once you hit 20 millimeter, the lateral pull on the patella, that Q angle vector, is just too strong. Even if you reconstruct the MPFL perfectly, the distal attachment point is so far lateral that the medial soft tissues just can't overcome that force.
So over 20 millimeters means you basically have to move the tibial tubercle medially. An osteotomy.
It strongly points that way, yes. If you ignore a TTTG over 20, any soft tissue procedure you do is probably going to fail long-term because the underlying alignment is just too far off. It's a surgical mandate almost.
Wow. Okay. And these measurements feed into a classification system, right? Du jour.
The du jour classification, exactly. Based on axial MRI, it gives us a hierarchy. 4 types, ranging from mildly dysplastic to, well, catastrophically malformed.
Can we use that ski slope analogy you mentioned, like mapping the types to the difficulty?
Yeah, let's do that. Type A is your bunny hill. It's shallow, sure, but still concave. There's some bony wall there. These folks might do okay with a non-op treatment or maybe just an MPFL reconstruction if the TTTG is normal.
Okay, mildest form.
Then type B, this is where it gets serious. It's flat or even convex. An inverted dome, forget a groove, it's more like a speed bump.
Zero containment.
Pretty much. The patella is just perched on top, ready to slide off. If you see type B, you're already thinking structural correction, possibly trochleoplasty. Just fixing the soft tissues won't cut it.
You need to carve a groove.
You got it. Type C adds asymmetry. The medial wall, the medial condyle, is underdeveloped, hypoplastic. So the lateral side is dominant. It creates this inherent lateral tilt or bias. The patella is sort of contained, but it wants to climb over that shorter medial wall.
Unstable containment.
Right. And finally, type D. This is the black diamond, the expert slope. You get the asymmetry of type C plus this vertical join, like a sheer drop-off, the cliff pattern.
Sounds bad.
It is bad. It's the highest degree of pathology. The consensus now is that symptomatic type D, and often types B and C too, really require trochleoplasty actually reshaping the bone, deepening that groove. Proximal or distal realignments alone just aren't enough for these severe types.
So the treatment follows the type. Non-op first, maybe MPFL for milder cases or good alignment, but for BCD, you're looking at potentially rebuilding the trochlea itself.
That's the modern approach. Early studies, like Insall's, showed good results with realignment, but they often excluded the really severe dysplasias. We now know that for types B, C, and D, you often have to address the bone directly with trochleoplasty to get reliable, lasting stability. The outcomes are generally good, but it's a bigger operation. You have to be realistic with the patient.
Makes sense. Okay, moving from the femur to the patella itself. The shattered shield, as the outline call it. We can skip this super rare stuff like congenital absence.
Yeah, like with nail patella syndrome, which is a whole systemic thing with kidney issues, iliac horns, very rare.
But the one we do see is the bipartite or tripartite patella.
Oh yeah, quite common actually. Maybe 2% to 5% of people have it. It's just when those extra little bone-forming centers, the accessory ossification centers, don't fully fuse with the main body of the patella during growth.
And the key pearl. Check the other knee.
Always. It's bilateral in about half the cases. So if you see it on the symptomatic side, get an x-ray of the asymptomatic knee too. Saves you trouble later.
And the location matters? There's a classification?
Yep, the SOP classification. Type 1 is down at the inferior pole, pretty rare, maybe 5%. Type 2 is on the lateral edge, about 20%. But the most common one, the one you'll see most often, is type 3. That's the superlateral pole, top outer corner. Accounts for about 75% of them.
Okay, so the big clinical question. Patient comes in, maybe after a minor bump, pain right over that top outer corner. Is it their chronic bipartite fragment acting up, or did they actually fracture it? How do you tell?
That's the classic dilemma. On a plain x-ray, the chronic bipartite fragment usually has smooth, rounded, maybe even sclerotic edges. It looks like it's been separate for a long time. An acute fracture line will look sharp, irregular, ragged.
But x-rays can be subtle.
They can. That's where MRI comes in clutch. It lets us see the bone marrow.
Ah, the edema signal.
Exactly. A chronic stable bipartite fragment, like the one shown in Fig 2.3, will have normal, dark marrow signal on fluid-sensitive sequences. No edema around it. The fragments are joined by fibrocartilage, not inflammation.
But an acute fracture.
Lights up like a Christmas tree. You'll see bright signal, high signal intensity in the marrow right around the fraction line due to the acute bleeding and swelling. That edema is the key differentiator.
And if it is symptomatic, not fractured, but just chronically painful.
Most are totally incidental, asymptomatic, you just note it. But if it is causing pain, often from sheer stress, especially that type 3 fragment getting pulled by the quad muscle and non-op treatment like rest and anti-inflammatories fails, then excision of that extra piece usually works quite well.
All right, shifting gears from bone to the soft tissues, the stabilizers. Let's talk about the missing staples, congenital absence of the cruciate ligaments, ACL or PCL, just not there from birth.
Extremely rare, like case report rare usually, and almost never in isolation. If you find a congenitally absent ACL or PCL, you need to look hard for other problems, tibial anomalies, genital patellar dislocation, leg length differences.
Larson syndrome for PCL absence, right?
Yeah, Larson syndrome is associated with PCL absence and multiple other joint dislocations. It points to a very early problem in development when the limb bud is forming.
So clinically, if the ACL is just missing, what clues do you look for? Does the knee feel unstable?
Surprisingly, yes. Even though the knee developed without it, you often find significant laxity. A positive anterior drawer, often a really loose Lachman, like a 3+ Slivener, and sometimes the other stabilizers are weak too, maybe medial or lateral instability as well. One study found complex instability in about 25% of cases.
And the x-rays show signs that the ligament was never there to guide development.
They do. You look for secondary signs. The spot where the ACL attaches on the tibia, the lateral aspect of the tibial spine, might be underdeveloped, hypoplastic. The whole space between the femoral condyles, the intercondylar notch, can be really narrow, looks like an A-frame. And the lateral femoral condyle itself might be smaller than usual. The joint just didn't get stretched out normally during growth.
Which leads to the big question. What do you do about it? Especially if the child isn't complaining. Observation versus reconstruction.
That's the million-dollar question, isn't it? It's a real gray area. Many of these kids are completely asymptomatic. Their muscles, other ligaments, they've compensated from day one. And we don't really know the true long-term consequences. It's not the same as tearing a normal ACL traumatically.
So the default is often watchful waiting.
For many asymptomatic kids, yes, observation only. The short-term results are often surprisingly good. We know reconstruction is a major surgery with its own risks, especially in a growing child with potentially abnormal bone shapes.
But isn't there a risk? We know ACL deficiency generally leads to meniscus tears and arthritis later. Are we just kicking the can down the road by observing?
That's the debate. We're balancing the unknown long-term risk of observation against the known risks and uncertain outcome of surgery in this specific rare population. We really need better long-term data, which is hard to get for rare conditions. For now, if the child is functioning well without instability symptoms, observation is often the first step. It feels like clinical restraint sometimes.
Of a tough call. Okay, let's move to the minutiae. Not absence, but weird attachments. Anomalous medial meniscus attachments. This sounds more common, especially in certain populations.
Yeah, much more common than absent cruciates, particularly noted in Asian patients during arthroscopy incidents, reported anywhere from 10% up to almost 23% in some series.
Wow, that high. And what's the abnormality? Where does the front of the medial meniscus attach, if not to the tibia?
Normally, it's got a solid anchor right onto the tibial plateau, but in these variants, it attaches somewhere else. The most common variant, almost half the cases in one large study, was insertion into the transverse intermeniscal ligament, basically. It attaches across to the lateral meniscus.
Instead of down to the bone.
Right. Or, the next most common, about 38%, it attaches directly into the ACL itself, less commonly into the coronary ligament or even the synovial fold below the patella. The point is, it's not anchored properly to the medial tibia.
And that lack of a solid anchor causes problems.
Big problems. It makes the anterior horn hypermobile. It flaps around too much. So when the knee moves, instead of the forces being spread smoothly, they get concentrated right at the junction between that loose anterior part and the more fixed middle and posterior parts.
Like yanking on a rope tied loosely at one end, the stress concentrates where it suddenly becomes taut.
Exactly that analogy. That junction, the mid-body posterior horn area, gets overloaded with shear stress, and that's where you see tears develop. Often without any specific major injury, just chronic overload.
So if you see a medial meniscus tear there, especially without trauma history, think about a possible anterior attachment anomaly.
Definitely keep it in your differential. Now let's talk about the discoid meniscus, the block of cartilage.
Right. The understanding of why this happens has changed, hasn't it? Affecting how we treat it.
Massively. For years, everyone believed Smiley's theory. The idea was that menisci start out as disc-shaped in the embryo, and then the center part resorbs to create the normal C-shape. So a discoid meniscus was just arrested development. It didn't finish resorbing.
Like it got stuck in an early phase.
But then Kaplan came along and challenged that. His theory, which is more accepted now, is that it's not really arrested development. It's a true congenital anomaly, likely related to abnormal attachments around the edge.
So the peripheral attachments are weak or missing.
That's the idea. Kaplan argued that because the meniscus isn't anchored properly at the periphery, it moves abnormally within the joint. That abnormal motion combined with joint forces might cause it to retain or develop that thick discoid shape. It's less about failed resorption, more about instability leading to abnormal morphology.
And that distinction matters for surgery. Is it just abnormally shaped, or is it unstable?
Crucial distinction. Okay, let's break it down. Medial discoid meniscus, very, very rare, like 0.1 to 0.3% incidence.
And symptoms.
Pretty much like a standard medial meniscus tear, usually presenting later in life, pain, maybe locking or swelling. X-rays are often normal. You need an MRI.
And the MRI sign.
You're looking for continuity. On the sagittal images, instead of tapering off, the meniscus looks like a thick band across the joint surface on more than 3 consecutive peripheral slices. Fig 2.4 shows it, well, just this block of tissue where you expect a C shape.
Okay. Now, the lateral discoid meniscus, much more frequent.
Way more common. Prevalence anywhere from 1.4% up to maybe 15% and even higher, like 16.6% reported in Asian populations. This is the one we see clinically.
And there are types here, too, based on attachments.
Yes. We classify them based on how much of the tibial plateau they cover, complete or incomplete, and most importantly, their posterior attachment. Most discoid lateral menisci, even if they're big, still have their normal posterior anchor to the tibia via the coronary ligament.
But then there's the infamous Risberg type.
Ah, the Risberg. This is the unstable one. The key feature is that it lacks that normal posterior tibial attachment, the coronary ligament. It's only attached posteriorly by the meniscofemoral ligament, the ligament of Risberg, which goes from the meniscus up to the femur.
So its only anchor posteriorly is to the femur, not the tibia, making it floppy.
Exactly. It's tethered higher up and more loosely, so the whole meniscus can slide forward and backward much more dramatically on the tibial plateau. This instability, combined with the bulky shape, causes that classic symptom.
A snapping knee.
The loud, often audible clunk or pop as the knee moves, especially into extension. That's the meniscus subluxating. It's reported in something like 60% of symptomatic cases.
Okay, so management. Historically, maybe total removal, especially for the unstable Risberg, but we know that's bad now.
We know total meniscectomy, especially in a young person, is a ticket to early arthritis. It just destroys the joint's load-sharing ability. So the paradigm has shifted dramatically.
Towards preservation.
Absolutely. For symptomatic tears in any type of discoid meniscus, the preferred approach now is arthroscopic, partial meniscectomy, and saucerization.
Saucerization. Explain that. You're basically carving it into a C shape.
Pretty much. You remove the torn, unstable parts, but then you contour the remaining thick tissue, trimming it down to create a more normal-looking, stable C-shaped rim. The goal is to leave behind as much functional, stable tissue as possible, like sculpting it into a functional shape.
And the data supports this. Less arthritis later.
Yes. Studies like the one by Lee et al. Looked at kids, and even after just 4 years, those who had subtotal or total meniscectomies showed way more degenerative changes on X-ray compared to those who had partial resection and saucerization. It really reinforces the need to preserve tissue.
What about the Risberg type, though? If it's inherently unstable because it lacks that posterior tibial attachment, can you really just saucerize it? Won't it still be unstable?
That's the tricky part. Traditionally, yeah, the instability often led to complete removal, but techniques are improving. There are reports now of successfully reattaching the unstable posterior horn, basically suturing it down to the capsule or tibia where the coronary ligament should be.
Trying to recreate that missing anchor.
Exactly. If you can stabilize it, then maybe you can just saucerize it and avoid total meniscectomy. It's definitely an area where surgical technique is still evolving. The goal is always preservation if possible.
Okay, let's talk about the infrastructure, the blood vessels, the nerves, the muscles. Starting with something that sounds quite alarming, popliteal artery entrapment syndrome, PAES.
Yeah, PAES is one you really don't want to miss. It typically hits young, active, often muscular males. Incidence isn't super high, maybe 0.16% or so, but the consequences can be severe leg pain with exercise or even acute limb ischemia if the artery clots off.
And it's caused by the artery getting squeezed.
Basically, yes. It gets compressed by abnormal muscles or fibrous bands in the space behind the knee, the popliteal fossa. Simple mechanism, but the anatomy causing it can be really varied.
A menagerie of causes, the outline called it. Like, what kind of things can trap the artery?
Oh, lots of variations. The artery might just take an abnormal path, looping around the medial head of the gastrocnemius muscle, the MHG. Or the MHG muscle itself might attach higher up or more medially than usual, pinching the artery against the bone. Sometimes it's an accessory slip of the gastroc muscle.
So the muscle's in the wrong place or just too big?
Could be either. Or it could be a tight fibrous band squeezing it. Sometimes the plantaris muscle is hypertrophied and causing trouble. There are classifications, usually type I through 6, based on exactly what is trapping the artery and how. For instance, type 3 is common, involving an abnormal origin of the MHG. Fig 2.11 does a great job showing these different anatomical scenarios.
Okay. And clinically, how does it present? How would you suspect PAES?
The most common story, in about half the cases, is activity-related claudication. Calf pain that reliably comes on after a certain amount of exertion, running, jumping, and goes away quickly with rest.
Sounds like exertional compartment syndrome.
Exactly. It's often misdiagnosed as that, or shin splints. But the scary part is the 5% or so who present with acute ischemia, sudden cold, pale, painful leg. That means the artery has likely thrombosed.
Yikes. So the physical exam is key, looking for pulse changes.
Absolutely critical. You have to do dynamic testing, check the pulses at the foot dorsalis pedis, posterior tibial at rest, then have the patient actively plantar flex their foot, point toes down, or you passively dorsiflex it, all while keeping the knees straight. If the pulses diminish or disappear with those maneuvers.
That strongly suggests compression.
Very strongly, because those movements tighten the calf muscles and can pinch the artery against the abnormal structure.
But to know exactly what's pinching it, you need imaging.
Yes. MRI or CT angiography is really the gold standard. It can visualize the soft tissues beautifully and show you the relationship between the artery and the muscles or bands. Is it the MHG? Is it plantaris? Is there a fibrous band? Fig 2.1 shows a great example of how imaging pinpoints the problem, which is essential for surgical planning.
And the treatment, if you catch it early.
If the artery itself is still healthy, treatment can be remarkably simple. Surgical release. You go in, usually from a posterior approach, identify the compressing structure, the muscle slip, the band, and release it, maybe resect a portion of it. That often cures the problem.
But if the artery's damaged?
If there's chronic scarring from repeated compression, or if it's acutely thrombosed, then just releasing the band isn't enough. You'll likely need vascular reconstruction too, maybe a bypass graft or a patch angioplasty to repair the damaged artery segment.
Okay, another vascular oddity, even rarer, the persistent sciatic artery.
Ah, yes, straight out of embryology class.
Yeah.
This is when the main artery that supplies the leg in the early embryo, the axial artery, fails to regress like it's supposed to. It persists into adulthood.
How rare is this?
Very rare. Incidence estimates are like 0.01% to 0.05%. Tiny. But the clinical kicker is its tendency to form aneurysms.
How high is the risk?
Shockingly high. Some series report aneurysm formation in up to 44% of cases. That's huge.
Wow. And where is this artery? How would you even know it's there?
It runs deep, following the path of the sciatic nerve down the back of the thigh, usually under the gluteus maximus. You might suspect it if you feel a pulsatile mass in the buttock or upper posterior thigh. The classic textbook sign, though often not present, is weak or absent femoral pulses, but strong pulses felt behind the knee and at the foot.
Why would the femoral pulse be weak?
Because often, in these cases, the normal superficial femoral artery didn't fully develop distally. It might be small or even stop altogether, and the persistent sciatic artery takes over supplying the lower leg. So you feel the sciatic arteries pulse distally, but the normal femoral pathway is weak. It's something to think about if you see weird occlusion patterns in a young person.
Okay, shifting slightly to muscle anomalies beyond just PAS. Anything clinically relevant there for us?
Mostly relevant during surgery, particularly graft harvest. We often take hamstring tendons, the pes and serenus tendons, for ACL grafts. We assume they'll be in the standard spot.
But they're not always.
Not always. One cadaver study found that about half the legs examined had some variation in how the sartorius, gracilis, or semitendinosus inserted. Maybe they were joined together differently or inserted slightly higher or lower. You just need to be aware of that variability when you're harvesting.
Any other muscle quirks? Like extra muscles?
Yeah, occasionally you see things like a third head of the gastrocnemius, or maybe the plantaris or semimembranosus muscle is unusually large, usually incidental. More relevant, perhaps, is hypoplasia specifically, underdevelopment of the VMO, that oblique part of the vastus medialis.
Why is that important?
Because the VMO is a key dynamic stabilizer preventing lateral patellar tracking. If it's underdeveloped, which happens in a fair number of people with patellofemoral pain, it contributes significantly to maltracking and instability.
Got it. Lastly, in this section, the nerves, specifically the one everyone dreads injuring in medial knee surgery, the infrapatellar branch of the saphenous nerve, IPBSN.
Yes, the IPBSN. Responsible for so much postoperative numbness and sometimes chronic pain around the front and medial side of the knee. It's just incredibly vulnerable during any anterior or medial approach.
Because it's right there in the field.
It's there, and its course is maddeningly variable. It can branch off the saphenous nerve high or low, run more anterior or posterior. There's no single safe zone.
Making it hard to reliably protect.
Extremely hard. Transection is common, unfortunately. And while numbness over a small patch might be acceptable, the real risk is neuroma formation when the cut nerve end tries to heal but forms a painful little ball of scar tissue. That can be debilitating.
So notorious that some surgeons just accept they'll likely cut it.
It's such a known issue with such high variability that, yeah, for certain approaches, trying to meticulously dissect it out might cause more damage than just accepting a clean transection and the resulting numbness. It's a risk-benefit calculation every time you make an incision there.
All right, final section. Let's look inside the joint lining itself, synovial structures. Starting with the very common popliteal cyst, or Baker cyst.
Baker cysts, yeah, we see these all the time on MRIs. Maybe 5% and 19% of knee MRIs show one. They're basically a fluid-filled sac bulging out the back of the knee.
And they form because of?
A one-way valve mechanism, usually. There's a bursa, a normal little sac, between the semimembranosus tendon and the medial head of the gastroc in about half of people. When there's extra fluid inside the knee joint, an effusion from some underlying problem, that fluid gets pumped back into this bursa.
And the connection acts like a valve, trapping the fluid back there.
Exactly. Fluid goes out into the cyst easily when the knee is flexed and pressure is high, but it can't get back into the joint easily when the knee extends, so the cyst fills up.
The crucial point here, especially in adults, is that the cyst itself isn't usually the primary problem.
Right.
It's a symptom.
Absolutely critical point. In adults, a Baker cyst is almost always secondary to some intra-articular pathology that's producing the excess fluid. Meniscus tears, arthritis, inflammatory conditions.
And the link with meniscus tears is particularly strong.
Incredibly strong. That study by Fielding et al. Is often cited. They found an 82% incidence of posterior horn medial meniscus tears in patients who had a Baker cyst confirmed.
82%.
Yeah.
That's almost guaranteed. If you see a Baker cyst in an adult, you have to look for a meniscus tear.
You absolutely have to. Treating just the cyst, like aspirating it or injecting it, is usually pointless because the underlying fluid generator is still active. It'll just fill back up. The MRI, like in Fig 2.15, is great because it shows the cyst and usually shows the underlying tear or arthritis causing it.
Management depends on age, then.
Big time. In kids, Baker cysts are often primary, not linked to pathology, and they frequently just resolve on their own over a year or two. Rarely need surgery. But in adults, you must treat the underlying cause. That means arthroscopy to fix the meniscus tear, debride the arthritis, whatever is driving the effusion. Address the source, and the cyst often takes care of itself.
Makes sense. Okay, last topic, plicae, these leftover bits of embryonic tissue inside the knee.
Yeah, plicae are fascinating. They're remnants of the synovial membranes that divided the knee into compartments during fetal development around 4 or 5 months. Normally, these membranes fully resorb, but sometimes folds or shells of tissue remain.
And there are 3 main types.
3 common ones: the suprapatellar plica, above the patella, the infrapatellar plica, below it in the notch, and the medial patellar plica, along the inner side of the kneecap.
Which one causes the most trouble?
The medial patellar plica is the usual suspect when symptoms arise. It's actually present in a lot of people. Estimates range wildly from 5% to maybe 55%, but it only becomes problematic in a small minority.
How does it become problematic? It's just soft tissue, isn't it?
It starts soft, but then something happens, maybe a direct blow, overuse, or just some inflammation in the knee, synovitis. This irritates the plica, making it swell up, thicker, less pliable. It becomes fibrotic.
And then starts causing mechanical problems.
Exactly. This thickened, tight band starts bowstringing across the medial femoral condyle, or rubbing against the edge of the patella during knee flexion and extension. It's like a windshield wiper rubbing on the cartilage.
Ouch. Leading to what kind of symptoms?
Often a dull, aching pain on the medial side of the knee, sometimes popping, clicking, catching, or a feeling of pseudo-locking. It can really mimic a meniscus tear or patellofemoral pain.
So how do you diagnose it? Is there a specific test?
Clinically, you often find point tenderness right over the medial femoral condyle where the plica impinges. There are also specific provocation tests like the Koshino and Okamoto tests, things like the rotation valgus test or the holding test, where you manipulate the knee and patella in certain ways to try and elicit that painful click or snap as the plica catches.
And if you go in with a scope, There's a way to classify what you see.
Yep. The Sakakibara and Watanabe classification is commonly used arthroscopically. It grades the plica from type A, just a small cord, up to type D, which is large with double insertions. The main culprit is usually type C, which is a large, thick, shelf-like structure covering a good portion of the medial femoral condyle. You can sometimes even see wear patterns or chondromalacia on the condyle where it's been rubbing. Fig 2.18 shows that kind of erosion.
And if it's confirmed as a source of pain and non-op fails.
Treatment is pretty straightforward. Arthroscopic resection, you just trim away the thickened, impinging band, usually very effective if the diagnosis was correct.
What about the other two plicae? Suprapatellar?
The suprapatellar plica is a crescent-shaped fold up under the quad tendon, found in maybe 17% of knees, usually asymptomatic, but if it's really large or gets inflamed, it can cause pain or clicking, or sometimes it can trap loose bodies, hiding them during surgery. Again, resection if it's proven symptomatic.
And the intrapatellar one, ligamentum mucosum.
The infrapatellar plica, or ligamentum mucosum, is actually the most common plica. It runs from the intercondylar notch down towards the fat pad. But here's the key. It's generally considered not pathologic. It very rarely causes pain itself.
So why do we care about it?
Its only real significance is if it's unusually large and thick, sometimes called a persistent vertical septum, shown in Fig 2.21. Then it can physically get in the way during arthroscopy, obstructing your view or blocking instruments trying to get to the back of the knee. In those cases, we resect it simply for access, not because it was the pain generator. #outro.
Wow. Okay, so we've covered a lot of ground, from bony malformations like trochlear dysplasia to these subtle soft tissue anomalies like plicae and weird meniscus attachments. The big theme seems to be you have to know the normal to recognize the abnormal.
Absolutely. You can't interpret the pathology correctly if you don't first identify the underlying structural variant. Was the foundation flawed from the start? Is there an extra piece of tissue causing friction? It dictates everything.
And realizing that a Baker cyst isn't just a cyst, it's a signpost pointing with like an 82% probability to a medial meniscus tear. Or knowing that du jour type D dysplasia basically mandates a trochleoplasty if symptomatic.
That's the clinical utility. That's the predictive power. Recognizing these aberrations changes your diagnosis, your surgical plan, and ultimately the patient's outcome. It's about understanding the starting point.
We also touched on several areas where the initial treatment is often observation, especially if the patient is asymptomatic, like congenital ACL absence or finding a discoid meniscus incidentally, or those Baker cysts in kids.
Right, which brings us to that really difficult clinical and ethical edge.
But what if?
Exactly. The source materials consistently highlight that for many of these observed conditions, the long-term consequences are still not fully known. We're making decisions based on short-term outcomes, but are we potentially allowing degenerative changes to progress silently?
So here's the final thought, maybe the question we leave everyone mulling over. When does the potential but unproven long-term risk of one of these structural anomalies justify intervening surgically on someone who feels fine right now?
Take that asymptomatic Risberg-type discoid meniscus. It's unstable, yes. Does that inherent instability guarantee problems later? Enough to warrant a prophylactic saucerization or repair in a kid who isn't complaining.
And specifically for saucerization, we think it's better than total removal. The short-term data looks promising. But do we have definitive multi-decade proof yet that it truly prevents arthritis down the line compared to, say, even more conservative approaches? How long do we need to wait for that gold standard data?
That gap between our current practices and truly long-term outcome data, especially for these less common congenital issues, that's one of the biggest ongoing challenges we face in orthopedics, balancing intervention with uncertainty.
A profound challenge indeed. Thank you for joining us on The Deep Dive.